Hey, this is AJ Clevenger here. We'll be doing an exam for our knee. We will have 3 projections for the actual knee, which would be an AP knee, an AP knee oblique with the internal rotation, and a lateral knee. We'll also be doing an intercondylar fossa tunnel shot, which will be using the Sedigas method. And our last shot, we'll be doing tangential patella using the Camp Coventry method. Alright, so we will go to our console before we bring in the patient. I'll be doing a knee here, so my technique would be around 75 kbp, the 5 mass for the AP and oblique. And when I go to lateral, I'll probably turn the mass over to 6.4, bump it up just a little bit. And that's pretty much our technique, using the table bucky and fixed technique. Bringing the patient to the x-ray room. Alright, sir.
Hello.
Hi, can I get your full name?
Yes, sir. Alfredo Pantoja.
And what is your birth date?
June 7th, 1985.
Okay, great. Can you tell me a little bit about what happened to your knee?
Yes, sir. I injured it.
You injured it. Oh, okay. So you want to take a history of what happened.
Yeah.
Okay, so now what we're going to do is put the gown on, and we're going to ask them also if it's, mostly if it's a female, we'll ask them if they're pregnant. So are you pregnant?
Not currently.
Okay, so not pregnant. Okay, so we're going to do the knee shots here. Alright, so we will be doing an AP knee exam here. We will have the patient supine with the gonad shield. We'll be using a cassette 10 by 12. We have the tube at an angle of 5 degrees because his pelvic is pretty large and it is more than 24 centimeters. So we have him at 5 degrees here, as you can see. So we gotta make sure that we have the center ray at a ½ inch below the patellar apex. We also want to make sure that the femoral epicondyles are parallel with the IR in order to get that true AP projection, and that the patella lies slightly off-center to the medial side. And make sure collimation is correct and our marker is out of the anatomy and is representing the left side. Alright, so next will be the AP knee oblique with the internal rotation. And for this shot, we'll make sure that the CR is still centered at the ½ inch below or inferior to the patellar apex, and immediately rotate the limb and elevate the hip of the affected side enough to rotate the limb about 45 degrees. We want to make sure that the collimation is correct, make sure we get all the anatomy that we need in the knee. We also want to make sure that the crosshair is still at the same place and that the marker is on the left side still and out of the anatomy. Now we have the lateral knee. We'll have the patient turn to his or her left side here, since when the affected side will be against most close to the IR. We'll have the patient swing his right leg over his left. Make sure we shield the gonads. We will also make sure that the affected knee has a 20 to 30 degree flex. We are going to center the center ray at the medial epicondyle there. The collimation will be all around the knee there. Make sure we don't do too much. We want to kind of make it a little tight. We also want to make sure that the marker is placed on the correct area, which is the left marker, and that way it's not in the anatomy either. For this exam, we will be doing the patella, which will be using a tangential projection, which is the Sedigas method here. The patient will be holding the IR with his or her left hand here. We'll be angling the tube perpendicular or even with the IR going through the patellar space. The center ray would be perpendicular to the joint space between the patella and the femoral condyles when the joint is perpendicular. We'll be using an 8x10 cassette, portrait wise, and this is the shot. The next shot would be the PA axial Coventry method, looking for the intercondylar fossa. In this case, we'll be angling the tube about 40 degrees to the intercondylar fossa, back of the knee there. The central ray will be right there, in between the condyles. We'll be using a 10x12 portrait. We'll make sure that our collimation is correct here. Make sure we get all the anatomy. Now, after each exam that is completed, we will bring the cassette over to the reader. We will find the barcode in back of each cassette. We will scan the cassette. Then, once the beep, we will put the cassette inside the reader. Then what the reader will do is bring up the image up on the monitor. Then from there, we critique. Hello everyone, we are going to critique the AP knee, and what we're going to do is we're going to make sure that we have all the required anatomy in our film here. What we're looking for is we need to make sure that the condyles are not rotated, which they're not here. We got the patella, which is superimposed, or right in the middle, right there by the femur. Let me see here. See it better here. Got the patella here. Another thing too is the spacing here, the intercondylar space, or the. We also have the tibial plateaus here. Also right here in the middle, we got the intercondylar eminence. And another thing too, so make sure we got the fibular head that's superimposed of the tibia. We also got the left marker out of the anatomy here, but it's still marked for left because we are shooting a left knee here. I think everything else was good on here. Right now we're going to critique the AP knee oblique internal rotation. So what we have here is we have the tibial fibular articulation right here. Zoom in right here. We have the spacing there. We also got the lateral tibial plateau, as we can see here. Right here on the left here, we have the medial plateau as well, including the intercondylar space here. We also have in the middle here, we also have the intercondylar eminence. Another thing we want to look at too is that our patella is off a little to the side here. As you can see, we don't want it too superimposed in the middle here of the femur. We want it a little, maybe a third of the way out, a little bit sticking out here, as you can see. And I think that's it. We also have our left marker representing the left knee. That's what we shot. I think that's good. So now we are going to critique the left lateral knee. So what we're going to see here is that the patella here is in a lateral profile. We also got the spacing here, which is the patellofemoral joint space. We got the condyles, the lateral medial, that are superimposed right now, the femur. We also have a slight superimposition of the fibula and the tibia in this area. We also got soft tissue surrounding the knee here. We also have the left marker marked. We also have the knee in a 20 to 30 degree angulation or flexed. What else? We also got the femoral tibial space here, and I think it's a good picture. You have good collimation here, and that's on our knee. All right, now we're going to critique the Sidiges method or the tangential patella. What we want to critique here is to make sure that we have the patellofemoral spacing here. You see here. We also have the patello here, free floating. It's a superimposition of any anatomy in this picture. And we got the lateral and medial condyles here. Looks pretty good. Pretty good collimation here. I think this method works well with this film here. Alright, for our last critique here, we are going to look at the intercondylar fossa. We have a method that's called Camp Coventry, or we just call it the PA axial projection. Our main thing, what we want to look for is the intercondylar fossa. It looks like it's elongated due to the tube inclination of 40 degrees. We're looking for the spacing here, which is the tibial femoral spacing. A little bit of it here. We also got the left marker out of the way. It's not in the anatomy at all. We have a little bit of superimposition of the fibula and the tibia. We can really see the intercondylar eminence right here. And also the patella is right in the middle of the femur here. That's really superimposition of it in the middle. It's a really good shot there. The collimation of this picture is good, and I think we have a great picture, and that's the end of our critiquing of our images.